to do a lumpectomy or do a mastectomy, removing that entire breast, and try and do axillary clearance, and then try to do radiation to decrease the spread of microscopic spread of tumor cells, and then try and do hormonal manipulation with tamoxifen if the person is estrogen receptor positive, meaning they will respond to an anti-estrogen medication. Stage 3 breast cancer, obviously greater than 5 centimeters, the mass itself here. The important thing here is that it had spread to the axillary nodes. This is where cancer spread, but it has not spread to the distal metastases, which involves the bone and also the liver. So breast cancer, the second most common form of cancer in our female population, second to lung cancer, but so much more easily preventable in our population, so much more easily diagnosed if we're cognizant of the fact that the incidences are increasing, but not only that, the diagnosis of it could be done much more early if we're actually aware, and it's so easy to palpate the organ itself because it's an external organ, and to actually be able to examine ourselves on a regular basis and bring it to our physician's attention, and getting a sonogram done to see whether or not that lump is solid or cystic, and a mammogram definitely indicated in our population, especially those of us who've got family history of breast cancer or a history of having ovarian or other endometrial cancer, ovarian or endometrial cancers as well. Lung cancer is the most common form of cancers in male, and the most common cause of death in a female due to a cancer, and second only to breast cancer as the most common cancer in a female. Lung cancer, as we fully well know, is obviously a cancer that occurs in the lung. But let's look at the anatomy of the lung itself and see the areas that could be affected and how we actually try to differentiate the types of lung cancers, whether it's coming from the bronchus or the lung tissue itself, and then try and see how the staging and differentiation of the areas that are affected and how it actually helps us with staging and the prognosis. When we look at the diagram of what the lung looks like, obviously we all could recognize that's the trachea with the paratracheal lymph nodes on either side, the carina of where the trachea splits into the right and left main bronchus, and then the subcarinal lymph nodes. Then you have the bronchus being split into the bronchioles, and then the rest of the parenchymal lung tissue. When we divide the lungs, we obviously try to divide the lungs in the upper, the middle, and the lower lobe on the left-hand side, and on the right-hand side it has a upper, middle, and a lower, with just a lingula itself. When we try to describe lung cancers as being it obviously is a rapid growing of malignant cells. And there are two big main differentiations of lung cancer. One in which there's a non-small cell lung cancer and a small cell lung cancer. Non-small cell lung cancer. And I always get calls by patients that they tell me that their relative has got lung cancer. But then your next question you ask them, is it non-small cell lung cancer or is it small cell lung cancer? I do not expect to have an answer to that at all times, but I expect you to have at least a histopathologic report that tells me even further. So when I ask you the question, at least you're able to give the answer as to what type of histopathological cancer it is, and then in addition to that, to tell us, as it spread outside, as it is spread to involve just the bronchus itself, just the trachea or the bronchus, or is it in the alveoli of the lungs? 80% of lung cancers are non-small cell lung cancer, and they form the majority of the cancers we see. Out of those cancers, the ones that are confined to the outer part of the lungs, which is the alveoli of the lungs, are called adenocarcinomas. The ones that actually involve the bronchus or near the bronchus are the squamous cell type of carcinomas, and then you have the large cell carcinoma, which can occur in any other part of the lungs. 20% of lung cancers fall under the category of small cell lung cancers, and those are the ones that tend to be much more rapidly growing and sometimes a lot more unpredictable in their behavior. So the majority of them, we know the behavior of the lung cancers, and much we're able to say from from the diagnosis what form of treatment is possible, whether it's come from an adenocarcinoma, squamous cell carcinoma, or a large cell carcinoma. The oat cell carcinoma itself actually involves the lymph nodes at a much earlier stages, and diagnosis is almost very difficult at times. Now you say to yourself, how do I know even if I have lung cancer? If you smoke, and you've actually smoked one pack of cigarette for in excess of 20 years, you can be assured that you will very well develop lung cancer. And I've known patients who have done that but have not developed lung cancers. But the general rule of thumb is 20 pack year of cigarette smoking can almost guarantee you developing lung cancer. Now, what is the incentive for someone stopping smoking? For those who have stopped smoking and over a 10-year period of time, their chances of developing lung cancers is about half to a third of those who continue smoking. So there's always an incentive at any point in time. If you smoke and you know that you can diagnose, that you can actually decrease your risk of developing lung cancer, it's best to stop smoking. Because it's not only lung cancers, but all the other forms of oropharyngeal cancers, even colonic cancers, even prostate cancers, it is found more and more likely that the smoking predisposes to an increased risk, but not only to yourself, also for those around you who are basically inhaling your secondhand smoke. How do you then know if you're developing lung cancer, or you should be screened for lung cancers? If you start to have shortness of breath and exertion associated with dyspnea, difficulty breathing, if you find that when you cough up streaks of blood, even though very much more common in an infective process, it's also more common to find it that in the cases of bronchogenic cancers, that you can actually be producing hemoptysis or blood-stained sputum, or even frank blood if it involves the bronchus itself. And these are the areas in which the sputum itself, when it actually expectorate, that basically that sputum itself can be blood tinged from the tomb itself invading it. But just imagine if the tumor is on the periphery of the lungs, there's literally no chance of you until it becomes a massive lesion that's actually spread to involve the lymph nodes that are draining it as well as metastasis. You are not going to be able to diagnose that. In addition to that, you have the shortness of breath, the hemoptysis. You also have the person with repeated amount of coughing. And this is coughing that's not amenable to any antitussive and continues to be that way. A person with significant weight loss, smokers themselves, the nicotine tends to decrease the appetite, hence that person is much more of a skinny or much more ideal weight for their height, and that's one of the sometimes the incentives for smokers. When I stop smoking, that's when I put on the weight, so I'm going to start back smoking. So I'm either going to die of the obesity or am I going to die of the smoking. The issue about that, it's to which method you want to choose. But knowing fully well that cigarette smoking is associated with lung cancer, you should actually use that. And if you're increasing the risk of those around you for development of other form of cancer because you want to smoke, then it's a very selfish act. You also will find in households of those who smoke an increased incidence of asthma or chronic obstructive pulmonary disease in the kids of those patients. The other signs you can find from lung cancer is if it has actually spread to involve the supraclavicular nodes and also to involve the axillary nodes. You can find there's evidence of an obstruction. That person develops a plethoric, swollen kind of face, but that is when the cancer is actually involved the supraclavicular nodes themselves. Much more likely for that person to find themselves loss of appetite, fatigue, malaise, go to the doctor, find out that the blood count has dropped significantly, they've got this mild hemoptysis, and then you start your investigation. But we hope that after an education that you do not have to wait for that stage to happen. You present to your doctor before. Obviously, when you present to your doctor, they will do a blood test to see whether or not there's any coexisting form of thyroid disease, that it can produce the same weight loss, loss of appetite. But in addition to that, you check the strength of the blood to see if that person has been bleeding. Obviously, in a case in which you have advanced bronchogenic cancer, you will be anemic. The issue is that you do a chest x-ray, you might find evidence of a lesion within the lungs. But a lot of times the chest x-ray is negative. You may find loss of lung volume in that particular x-ray that you do and find that evidence of that patient having a very large lung, which is consistent with a smoker with chronic obstructive airway disease. You have these large emphysematous lungs in which you're able to see right through because they're just trapped with air within it, and then you may find evidence of the carina or evidence of lymph node enlargement, And definitely, you know, when you see that with a person with a history, definitely you may be dealing with bronchogenic cancer that has spread to involve the lymph nodes. Other tests that are available as a next step is to get a PET scan with a positron emission tomography scan, which is you label the glucose, which is absorbed by the cancer cells, and you can actually have a positive results because it's absorbed. They've actually rationalized it to involve a PET scan and a CT scan, where you're actually able to label the glucose that's being absorbed by the cancer cell, at the same time get the anatomy of the lung to find out exactly where that area is. This is what a PET scan would look like when you actually try and diagnose where the lesion is. Afterwards, an MRI is probably much more diagnostic in telling us exactly where the lesion is. After you've diagnosed it, is basically to try and treat it at that stage, or try and biopsy the lesion to find out what kind of cancer it is and try and effect the most effective cure at that stage. We are hopeful that we don't have to reach a stage where we have to use a lot of diagnostic tools. We can try and prevent lung cancer before it gets to this stage. Okay, the treatment choices in itself for lung cancers are mainly palliative, and at best, your life survival after diagnosis of lung cancer is extremely small. In fact, 5-year survival is probably less than 20 to 30% of the population that I tend to see with advanced lung cancers. As we continue a discussion into the question being asked, very commonly asked by patients as to what causes cancer, and not being able to answer it, as I'm sure most oncologists or even physicians, there's no simple answer to cancers except to try and differentiate the different cancers and see what the common cause is of that particular cancer. What is the common cause of it? How does it present? And it makes the patient aware that they should be seeking the help of the physician in order to help to diagnose it at an earlier stage, and to have an idea of those cancers, how it's being described. When your doctor describes to you that your prostate cancer is a Gleason 1 or Gleason 5, you're able to tell your relative, well, I've got a good or a bad prognosis. If you're able to say, I've got blood in my semen, is this significant for me? And is it significant for prostate cancer? And those are the answers that most people try to get from their physicians, and try to understand the disease process, not as if you're diagnosed with a cancer, but you're diagnosed with a cancer of a prostate. It's not as if you live in Richmond Hill. You live on 12507 Liberty Avenue in Richmond Hill. So you have to be as specific as possible as you undergo an education process as to what cancers are. And this is so significant for us to understand in terms of being able to have a healthy and a clear understanding what cancers are. One of the most common cancers that I've seen in increasing numbers in my practice is prostate cancer. And despite reading on prostate cancer as a medical student and a resident and a consulting physician, the most common presenting complaint of prostate cancer is no complaint at all. In fact, it is the finding of a random test done on a person over the age of 45 to do the prostatic specific antigen, and then finding out that that level is higher than usual. Usually, obviously, you know, because prostate cancer has a genetic propensity for development. In those with first-degree relatives, you tend to be much more vigilant in screening for prostate cancer in those individuals, and always educate them that it is so important for them to tell their physicians that they do have a father or a brother who has got prostate cancer, and much more significant if that prostate cancer was diagnosed under the age of 45 to 50. To understand prostate cancer is to understand it's it's the second most common cancers in male, second only to lung cancer. And it's not as aggressive a cancer as lung cancer is, and the long-term prognosis of it is much better. With a PSA level, or a prostatic specific antigen, being such a diagnostic tool that's readily available, there's no reason why we should be seeing cancer of the prostate in advanced stages. And rather than go through the clinical manifestations, the diagnosis, and treatment, I would like to show you a diagram that outlines the various degrees of prostate cancer, why it is so important for us to understand that the minute you feel as if you have any symptoms, any urinary symptoms, either hesitancy, you cannot pass urine freely at nights, you feel as if you have to get up in the morning, get up during the nights to pass urine, you find there's some blood tinge in your sputum or in the semen, you find a problem with erectile dysfunction, you find something, even the passage of stool becomes difficult, it's always important for you to bring that to the attention. We look at the transverse colon here again, unless it's a lesion that produces evidence of obstruction, then it's probably a circumferential lesion that invades around the gland. Then it's probably difficult to make the diagnosis early. In a case in the descending colon, when the lesions present, it's much more easy for the surgeon to be able to biopsy, the gastroenterologist to biopsy the lesion and come up with an earlier diagnosis than usual. But the lesions on the left-hand side makes it so much more easier. The lesion adenocarcinoma of the rectosigmoid junction make it so much easier for us to get symptoms early. The stool will not be able to pass this lesion unless it becomes very narrow pencil-like stool. Or in addition to that, it becomes tinged with blood. And then the blood, the bright red blood, is what brings the patient to the doctor. In that case, the person comes in with, doctor, I've got a change in bowel habits. Now I'm not able to pass stool freely. I'm passing pencil stool. Or I've got alteration of diarrhea and constipation, which usually occurs in a lesion that basically is obstructing the passage of stool and then allowing the stool to pass freely at times when it's more liquid stool. So they have this alteration of diarrhea and constipation. In a case in a lesion which has actually gotten so large that it started to feed on the patient, in that case, that large fungating mass, the patient would present. And I've seen cases where patients present with anemia, profound anemia, with a blood count as low as 4 to 6 grams per deciliter of hemoglobin. In a case like that, that patient literally looks extremely pale, tired and fatigued. I've even found a patient who developed congestive heart failure, had to be admitted because of profound anemia. And the cause of the profound anemia was the evidence of the large fungating lesion which was in the colon. So sometimes it is the index of suspicion of that elderly person who comes in with the unexplained tiredness and fatigue, nothing to do with bowel function. You find out there is evidence of a decreased hemoglobin hematocrit. You find that they have evidence of congestive heart failure. Then you need to find out what is the cause of the anemia. As part of your investigation, it's not to find out that person is anemic, what was the cause. Find out that you basically do an incomplete blood workup, that it shows that the anemia is there. You may decide to do a stool test, but you can find evidence of trace blood in the stool. But that in itself is very common, because so is the area around the rectum with evidence of perianal hematomas, hemorrhoids, especially in our situation with the kinds of food we eat. Lesions around the area associated with our gastroesophageal reflux disease from the dyspepsia and the burning that produces the rectal area, around the rectal area. We find a large number of us will have evidence of alterations in bowel habit, pain during defecation, and even a mild amount of blood based on the spiciness of the food and the pepper involved in it. It will cause an excoriation of the area around the rectum. And a lot of times we sometimes take that for granted and say, well, the patient just had evidence of hemorrhoids, where in fact we miss the bigger picture that that patient had a lesion within the colon. It's extremely important to have that index of suspicion within us, especially if we have a family history. If you've got a family history of ovarian and uterine cancers, there's an increased risk in the female population of having colorectal cancers. In the male population, those of us who are diabetic, and those of us who have an extravagant lifestyle with alcoholism and cigarette smoking abuse, your incidence of colorectal cancer is much higher, especially associated with that with a lack of exercise, in addition to that with a large consumption of red meat. So a lot of the things we do predispose us for the development of colorectal cancer. But knowing fully well a lot of the other symptoms that you can get from benign colorectal disease, you can get blood in the stool from hemorrhoids, which are easily treatable, perianal hematomas, perianal fissures. You can get alterations in bowel habits based on a simple fact on the foods we eat. You can get penciling of your stool based on the fact of sometimes our abnormal habits of not eating enough fiber can give us that kind of nature. We can have alterations of bowel habits based on the fact of how we eat as well. For those of us who consume large amounts of carbohydrates and develop diabetes, we know we increase our risk factors for colorectal cancers, but we also can cause ourselves to develop things like gastroparesis, where the emptying from the stomach delays the passage of food into the gastrointestinal tract. We stop exercising. We do not drink enough water. A lot of those symptoms are manifested itself in the gastrointestinal tract. And even though colonic cancers are becoming increasingly common or are diagnosed much earlier, it is also important for us to narrow down within ourselves when we think we're at risk. Because if all of us start to think that we're developing colon cancers, then we'll have a lot of unnecessary testing done with colonoscopies, and then it becomes less cost effective, and then we start to have rulings made by the government regarding who is entitled to having a colonoscopy done. Right now, at this point in time, is to educate ourselves what are the more common things that we find in colon cancers, and being able to present that to our physician, knowing fully well that the staging of cancer, as I told you before, always try and find out in stage 1 cancer that is restricted to the mucosal lining. Stage 2 cancer, actually a larger cancer than usually over the size of the stage 1, but is involving the mucosa. Now the stage 3 cancers involve the mucosal lining and has gone outside of the rectal wall or the colonic wall, and stage 4 has gone beyond that to involve the lymph nodes and has also spread to the pelvic area itself. In a stage 4 cancer, also known as Duke D classification, the prognosis is a 5-year, 20% survival, meaning 20% of those patients who are diagnosed at this stage will be expected to live beyond 5 years. In a case like this, in which a stage 1, it can be curative if that area is resected, and you probably can end up with a colostomy for a while, and then afterwards reanastomosis of let's say the cancer is over this area, removal of the cancerous lesion, bring out the colostomy bag, start having it there, and then basically when the lesion is healed, do a secondary closure and being able to not to have a colostomy bag for the rest of your life. If in the case, however, the cancer spread to involve the rectum and this area, we may be faced with having that colostomy bag for the rest of our lives. Hopefully, if we're free of cancer, it may be a burden to carry, but not an unnecessary one. Obviously, the diagnosis is made in terms of the medical history, the physical examination being done, and obviously to look in terms of as a cancer spread outside of the abdomen. When you're examining the abdomen of the patient, to look and see whether the abdomen is pedunculous, whether or not there's evidence of ascites, meaning the cancer spread outside of the colon, involve the liver itself, and then you have ascites. You can have evidence of lesions that appear on the skin itself. You can have evidence of varicocele in the cases in which you actually develop obstruction to the passage of the venous blood supply. Those are advanced stages of colonic cancer that actually involve metastases. The treatment of choice, however, depends on the staging of the cancer and also the degree of spread of that particular cancer. Here again, that in itself is the diagnosis of it, obviously made from the physical examination, the history given by the patient, the physical examination, the laboratory tests being done, and X-ray probably just can show evidence of obstruction. If there's evidence of multiple fluid ear interfaces, that suggests there's obstruction. A CAT scan probably, in addition, to tell us whether or not there are lymphatic nodes that are spread outside of the gut itself to involve the lymph nodes in the abdomen itself. An MRI done as well. A lot of times the explorative laparotomy to see where the cancer spread is also diagnostic and curative as well when actually having the chance to look inside of the abdomen. There are other cancers that we can probably pay attention to, but I think haven't put our attention towards breast cancer being the second most common cause of death in the female population is significant for us. Lung cancer we discussed as well as the most common cancer in males and the most common cause of death in males, and second most common cause of death in females. We also describe prostate cancer, a cancer that's so easy to diagnose very early, and then colorectal cancers. Hopefully in the next discussion we'll be able to deal with some other cancers, the oropharyngeal cancers, the cancers involving the brain itself, cancers involving the the renal system, the kidneys, the ureter and the bladder, and other forms of bone cancers as well. And that's all for now.